get started? So hi everyone. Thank you for calling in during this lunch hour. My name is Cliff. I hope you can hear me okay. If you have any questions, just send us a message. So it's my pleasure today to being here talking about medications and chronic kidney disease. It's a large topic, and I usually get a lot of questions after the the presentation. If you do have questions, please send us a message, and we'll try to answer them at the end of the presentation. Also include your email address, just in case we run out of time. I could send you an email after. If you're interested in seeing these slides again, it's available 24/7. You can Google it, medications and CKD Prezi, and it'll be the first link that comes up. Are you hearing okay? So as I mentioned, it's a large topic, and we're going to talk about common prescribing questions for patients with chronic kidney disease not on dialysis. And what we decided to do is focus the presentation today on questions that we commonly get. In fact, these questions are so common that the Renal Agency has put together this document. It's available on the website to help prescribers with these common questions that come up. And so for example, it does contain recommendations to do. For example, the first recommendation is for gout treatment. We know we should avoid NSAIDs. And so the Renal Agency suggests colchicine, prednisone, and uric acid-lowering agents. And so I'm not going to go through all what's on this document in detail. It's available on the website. What I'm going to do during this presentation today is really go through the rationale of why these recommendations exist in some of the literature and controversies. So I'll also talk about urinary tract infections. There's a lot of controversy of whether we should use nitrofurantoin or not in patients with lower kidney function, and I'll talk about that. We'll talk about shingles. Maybe once a year or once every 2 years, one of our dialysis patients will end up in the emergency room because of a prescription of Tract that they received for treatment of shingles that was not adjusted for kidney function. So we'll talk about that. And also, if you're going to treat postherpetic neuralgia, if you're going to use pregabalin or gabapentin, just remember to adjust the dose for kidney function. And also we recommend avoiding morphine due to the accumulation of toxic metabolites. Hydromorphone and fentanyl are much more clean. We'll dedicate a bit more time on preventing acute kidney injury, and I'll explain why that is. And lastly, we'll talk about colonoscopy preparations and what preps are safe to use in patients with CKD. Really, the short answer is avoid phosphate-containing bowel preparations and use PEG 3350. So as I mentioned, we're going to spend a little bit more time on acute kidney injury, and this is because when we talk about preventing progression to end-stage renal disease, we often think about three things. One is controlling blood pressure, 2, controlling blood sugar, and 3, controlling proteinuria or reducing proteinuria. But what I would like you to do is keep preventing acute kidney injury right up there in terms of interventions that are important. There's not many interventions that prevent progression of end-stage renal disease, and I'll explain this. So we know that AKI is increasing. Statistically, you can see the lines going upwards, or the trends going upward. This is because the patient population is getting older, with more comorbidities and taking more medications than ever. The concern with AKI is that it leads to progression of end-stage renal disease, amongst other things. And so looking at the data here, you see at time 0, if somebody has an episode of acute kidney injury, 3 years down the line, the risk of having end-stage renal disease and needing dialysis or a transplant is 30% greater if that patient did not have the AKI episode. And that red line there is the line for patients with pre-existing chronic kidney disease. If you do not have pre-existing chronic kidney disease, your risk at 8 years is about, 3 years is about 8%. And so AKI doesn't just lead to end-stage renal disease or increase your risk of end-stage renal disease, it also increases your risk of other bad things such as mortality. I just wanted to throw this slide in here. This is a landmark trial by Chertow published in JASN in 2011. And what they did here was they looked at patients who presented to the emergency room, had a serum creatinine checked, and had another serum creatinine checked within 48 hours or 48 hours later. And what they had found, and they just observed those patients over the hospital stay, and what they found was that just small increase in serum creatinine, such as you can see here, 26.5 micromoles per liter, increased the risk of mortality during that hospital visit by 4 times, even adjusted for potentially confounding variables. So as we learn more about acute kidney injury, we realize that it's not just something that affects the kidneys, it also affects, we have increase in stress hormones and inflammatory mediators that occur that increase in places like the brain and the bone and everything in between. And so how we want to view acute kidney injury is that the kidney is a robust organ. It can tolerate exposure to several insults without suffering significant or structural functional change. Any change in kidney function, even small changes, indicate severe systemic derangement and predict a poor prognosis. We should think of AKI more like an acute lung injury or an acute coronary syndrome, where early detection and treatment may actually improve outcomes. And of course, the treatment depends on etiology. And you're going to do your diagnostic workup and possibly include a nephrologist in that. But if you look at any phase-based or stage-based management of acute kidney injury, always at the top of the list is discontinuing nephrotoxic agents. So this is how it ties back to my talk to you on medications in chronic kidney disease. So medications or nephrotoxic drugs account for a portion of AKI or directly cause AKI in 20 to 30% of patients. And so we want to identify these drugs and stop them. I can talk for about an hour on drugs that can cause nephrotoxicity, but today, due to time constraints, we're going to focus on the main ones that we'll see in patients with patients in the community, and so which are ACE inhibitors, angiotensin receptor blockers, anti-inflammatory medications, such as NSAIDs specifically. And this document that I'm showing up here right now is called Medication Changes When You Are Sick. It's provided to all of our kidney patients who attend a kidney care clinic here in British Columbia. And what it does is try to prevent acute kidney injury. So what it says here is that if you're vomiting or have diarrhea or feel very sick, try to drink fluids. If you're so sick that you can't drink your normal amount of fluids, then stop taking the medications listed below, and the clinics will write down the medications the patient is taking until they're able to start drinking fluids again. And if this lasts for more than 48 hours, to seek medical attention. So this often comes, the question often comes up from patients that you're telling them to hold their ACE inhibitor or ARB because it could potentially be bad for the kidneys, but at the same time you're prescribing it to help with their kidneys, and so what's the story with that? And so we can best explain that by looking at the glomerulus and the physiology of the kidney. We have the afferent arteriole, which brings blood flow to the glomerulus, where the filter is. And then we have the efferent arteriole, which brings blood away from the glomerulus. When you prescribe an ACE or an ARB and give it to your patient, what it does is it vasodilates the efferent arteriole. If you vasodilate the artery that's bringing blood away, then you would decrease intraglomerular pressure and decrease filtration rate, and decrease glomerular filtration rate, that is. And so if you give this to a patient, or if I took an ACE inhibitor right now, I'm not going to go into acute kidney injury. The risk of acute kidney injury is really when renal perfusion pressure is low, such as when a patient has decreased cardiac output, such as acute decompensated heart failure, patient's volume depletion from diarrhea, dehydration, or the third spacing. AKI is also a concern when the patient has bilateral renal artery stenosis. So we talked about the decreased intraglomerular pressure that contributes to AKI when there's decreased renal perfusion. And along the same lines, this is how ACE inhibitors and ARBs are beneficial in terms of protecting the kidney, specifically in patients with, who have protein crossing that barrier. So not only does it reduce intraglomerular pressure, therefore less protein crossing, it increases selectivity of the membrane to proteins, and therefore less protein gets through. And of course, protein should not be filtered across the glomerulus and make its way to the proximal tubule. When it does get into the proximal tubule, what happens is the body or the proximal tubule will reabsorb it or try to reabsorb it, and that process causes inflammation and it causes scarring to the nephron. And eventually, you get damage to the nephron. At the same time, because ACE inhibitors and ARBs block angiotensin 2, you could reduce intrarenal angiotensin 2, and angiotensin 2 is a growth factor. When you think about things like heart failure, you want to block angiotensin 2, and that prevents fibrosis, and the same thing is thought to occur in the kidneys as well. So when you look specifically at how ACE and ARBs prevent progression of kidney disease, it reduces protein getting through the glomerulus and entering the proximal tubules. That is beneficial in patients who have proteinuria or albuminuria, and specifically beneficial in patients with diabetic. Because when you think about diabetes, diabetic nephropathy occurs when first occurs with hypertrophy or hyperfiltration and eventual protein spilling into the urine. So it's really beneficial only in patients in terms of progression of kidney disease in patients who have proteinuria. For patients who do not have proteinuria or diabetic patients, the use of ACE and ARBs has not been shown in any study to prevent progression of kidney disease. There's meta-analysis and there's studies that have been done on this, and I have one reference, the second reference at the bottom if you want to read this data. So if that is the case, if your patient has CKD and they do not have proteinuria and they do not have diabetes, then really, and no other compelling indications, you can choose any blood pressure you want in terms of controlling blood pressure based on the side effect profile and cost of the medication. There's no evidence to guide first-line treatment or second or third-line treatment. And Dr. Levin will talk about blood pressure management right after me, so that's about as much as I'm going to talk about blood pressure. But there is some, while we're on the topic of renin-angiotensin-aldosterone system, there is renewed interest in aldosterone antagonists. And it certainly does have proven benefit in non-CKD patients with severe heart failure, the ejection fraction less than 30%, resistant to other therapies such as an ACE inhibitor. And the theory behind this is that about half the patients who are prescribed an ACE or an ARB, you get a breakthrough in aldosterone production, and it restores to pre-treatment levels after a period of months. And so you can really achieve good blood pressure lowering by which is small doses of spironolactone, 12.5 to 50 milligrams a day. Now, in the older studies, or the first studies when spironolactone first came onto market, they were using doses of 150, 200 milligrams a day as a starting dose, which caused a lot of gynecomastia and hyperkalemia. When we're using small doses like we do now, those risks are much lower. Regardless, when you look at any of the guidelines or the drug monograph, there is still a caution to avoid aldosterone antagonists if the eGFR is less than 30 mils per minute. And this is specifically due to the risk of hyperkalemia. Despite this recommendation, we do have seen a few dialysis patients who are on spironolactone. And if you monitor for hyperkalemia, you can actually, it is quite an effective medication. So the reason why I'm talking about aldosterone antagonists is because of that, the data that I just presented to you, but there's also newer interest in it as a medication that reduces proteinuria, especially in combination with ACE and ARB. You get that eventual normalization, or some 50% of patients get that breakthrough in aldosterone. And so there's the two studies published back in 2006, both combining an aldosterone antagonist with an ACE inhibitor, and both studies showed a greater reduction in urine albumin compared to ACE inhibitors alone. And again, protein being something that is toxic to the kidneys. However, in 2014, there's a Cochrane review. It did review all the evidence that was out there. They did find a reduction in proteinuria in CKD patients, already on ACE inhibitor and ARB, but there was a risk of hyperkalemia. But they did find no improvement in eGFR. And so really there is interest in aldosterone antagonists. It's a very cheap medication, but the long-term effects are not known. One of the interesting things is that there's going to be an upcoming trial that's looking at preventing progression of cardiovascular disease in patients with CKD. That's going to hopefully be published in the next year or two, called the BRAC-D trial. So we'll look out for that. And that's what I'm going to talk about in terms of hypertensives. On this list, we also have the point where we hold metformin. And metformin is not a medication that does cause, that can contribute to acute kidney injury. The reason why we want patients to hold metformin when they're having diarrhea and not drinking normally is the risk of lactic acidosis. Now, metformin produces lactic acid as part of how it works. It converts glucose to lactate in the splanchnic bed in the small intestines. Excuse me. It decreases hepatic gluconeogenesis from lactate, pyruvate, and alanine. And so in short, when the GFR deteriorates, not only is there a decrease in lactate excretion from the kidneys, but there also, metformin rises, its concentration rises above its therapeutic range. It blocks hepatic uptake of lactate and really provokes lactic acidosis. So that's the mechanism. But there's controversy with metformin and if there's actually a risk for lactic acidosis. And for those who don't believe in lactic acidosis resulting from metformin, a lot of people will quote a Cochrane review that was published in 2010. And in this Cochrane review, what they actually found was that patients who take metformin actually had a lower risk of lactic acidosis than those patients who did not take metformin. And their conclusion was that metformin does not cause lactic acidosis. But just a warning with systematic reviews, the data coming out of a systematic review is only as good as the data going in. The study populations or any studies that have been done with metformin typically exclude patients with heart failure, with hepatic failure, kidney failure, or any hypoxic state such as shock or sepsis. And those really are the conditions that lead to a lactic acidosis when you use metformin, so be very careful with that. We've had a number of cases, just anecdotally, where metformin has, we believe, caused lactic acidosis in our dialysis patients. So be vigilant. We do recommend holding it. If there's lactic acidosis, there's reports of lactic acidosis with AKI post CT scan with contrast, so the recommendation is to hold metformin 24 hours before CT with contrast and 48 hours after, and to check serum creatinine before restarting metformin. And also to consider holding metformin when there's cases when your patient is at risk of tissue hypoxia, such as an acute myocardial infarction, acute decompensated heart failure, or sepsis. Really, insulin is a much safer option in those cases. In terms of dosing metformin, some monographs do say that you really shouldn't use it if the GFR is less than 60 mils per minute. All the different recommendations, you can see this recommendation in many places, I believe, Lexi Drugs and RX Files support this. And you could just basically adjust the dose down, but really avoid it when the GFR is less than 30 mils per minute. The next topic we're going to talk about is gout management. And really, this is a general recommendation for all patients with chronic kidney disease, is to avoid NSAID use because it does vasoconstrict the afferent. So we talked about the efferent arteriole when we talked about ACE inhibitors in ARBs. The afferent, remember, is the blood, the artery that brings blood to the glomerulus. And if you're constricting that, you decrease glomerular filtration rate as well. And again, when you combine it either with an ACE inhibitor or the patient's dehydrated or decreased intravascular volume, then the risk of acute kidney injury increases and all the bad things that come along with that. Some people wonder if COX-2 inhibitors are a better choice. It is not, because the vasodilatory prostaglandins are produced by COX-2. And so the general recommendation in any pain guideline or algorithm is to avoid NSAIDs in patients with the GFR less than 60 mils per minute. For gout specifically, colchicine or prednisone are good options, and uric acid lowering agents if there's more than 2 attacks per year. Now, I'm going to focus a little bit more on allopurinol because there's a lot of interesting stuff happening with it and a bit of controversy. So we know that at least physiologically, when serum acid levels increase about 360 micromoles per liter, that's the point where it can start to saturate and precipitate into joints and cause things like gout. And so the target really is to try and get serum acid levels less than 360. And if you're using allopurinol to do this, you may actually need to use doses above creatinine-based guidelines. And so this is from, you can see this in any textbook. I know it's kind of small, but when you're looking at it, it'll tell you, based on your creatinine clearance, you should only use, say your creatinine clearance clearance is 40, you should only use a max of 150 milligrams a day. That may not actually be enough to lower serum uric acid levels less than 360. And so if you look at newer recommendations, for example, if you go with Lexi drugs now, it's not so strict in terms of the creatinine-based recommendations. It will tell you can use this treat to target recommendation. But the thing to watch out for is hypersensitivity syndrome. And that's the concern with using higher doses in patients with chronic kidney disease. It's associated with hypersensitivity syndrome. Happens in less than 1% of all patients who are prescribed allopurinol, but if it does happen, it can be quite serious. Specifically, hypersensitivity syndrome typically occurs within 2 to 8 weeks after initiation. So it's really when you first start this medication, it's a hypersensitivity syndrome, it's an allergic reaction. It's debatable whether chronic kidney disease has anything to do with allergic reactions, usually genetics and other factors. But regardless, you see those creatinine-based recommendations. To diagnose hypersensitivity syndrome, you need 3 of the following, including skin manifestation. So you need to also have either fever, organ involvement, such as the liver. You should check liver function tests, swollen lymph nodes, or hematological abnormalities. All those things have to exist to actually have a definition to diagnose hypersensitivity syndrome. It's very rare. So with that question, in 2011, an RCT was done. It was an open-label cohort study. Sorry, it was not an RCT, it was a cohort study. What they did was they looked at a group of patients, and what they did was they increased allopurinol and targeted a serum uric acid level less than 360 compared to a group that followed creatinine clearance-based fixed dose recommendations. And they increased allopurinol dose carefully, just by 50 to 100 milligrams every month, and monitored those patients for hypersensitivity syndrome. And what they did find over the duration of the study was that 90% of the patients in the intervention group achieved that target of serum uric acid less than 360. The median allopurinol dose was 450 a day, quite elevated, or quite a large dose. And importantly, there was no major adverse drug events with increased allopurinol doses above the creatinine-based dosing recommendations. And so there's some evidence to support the use of doses higher than the old creatinine clearance-based recommendations. And not only that, there is additional interest in allopurinol, certainly being used in patients with lower GFRs. And that's because there's this hypothesis that allopurinol slows renal disease and reduces cardiovascular risk in patients with CKD. And this is due to data that has come out that has associated high uric acid levels with hypertension, uric acid with inflammation, and increased glomerular hydrostatic pressure. And when you look at, this is one study done in 2010, they randomized a group to allopurinol versus control. Mean baseline GFR was 40 mils per minute, the serum uric acid level was 430 micromoles per liter. The group that got, if you look at the figure on the left, the group that got allopurinol dose, allopurinol treatment actually had an increase in GFR of about 1 mil per minute. The group that received placebo actually lost GFR about 3 mils per minute. And when they followed it over the study duration of 30 months, they found that the group who got allopurinol actually had less cardiovascular events. And so there is renewed interest in allopurinol. Hopefully we'll see more studies in the near future, but certainly being used at higher doses and lower GFRs than we used to do. And so on the topic of uric acid lowering agents, there's also Febuxostat. It works just like allopurinol, just has a slightly different structure, inhibits xanthine oxidase. There is a trial. It's debatable whether people believe this or not. It showed that Febuxostat was more effective than allopurinol at a fixed dose, which many people think is unfair. So it was better than a fixed dose of allopurinol in terms of lowering serum acid levels. It did not show reduction in gout attacks or pain. Other things to consider with Febuxostat, it doesn't require renal dosage adjustment. However, at the same time, there's really no long-term data of safety in patients with CKD, and it costs about twice as much. So moving on to shingles, in terms of primary care providers, the average family physician with a base population of about 2,000 will see about 4 to 8 cases per year. Antivirals are recommended in very specific circumstances if it affects the eye, if it's disseminated, if the patient is immunocompromised. For immunocompetent patients, the patient really should present within the first 72 hours of rash onset. And what we're trying to achieve when we give a patient an antiviral is a reduction in 1 to 2 days of lesions, but more importantly, preventing the duration of hepatic neuralgia. It reduces it from about 90 days to 1 month or 2 months. The problem with this use is neurotoxicity. And this really exclusively occurs in patients with CKD, and it typically occurs if the dose is not adjusted for the level of creatinine clearance. Within 24 to 72 hours of treatment, these patients present confused, they present sedated, and it quickly goes away after you stop the medication. If you look at the evidence for the literature, by 2009 there was about 20 cases published of acyclovir or valacyclovir neurotoxicity. 85% of those patients had chronic kidney disease. The other 15% developed acute kidney injury prior to symptoms developing. So really this is, again, a condition that only occurs in patients with reduced kidney function. Most of those patients have clearly received excessive doses. On the market here in Canada is also an antiviral called valacyclovir. I did a quick PubMed search and found there was also a case report of neurotoxicity. Neurotoxicity is certainly listed as a side effect in the monograph of valacyclovir, but because there's less case reports of valacyclovir neurotoxicity, the question comes up of whether it's more less neurotoxic than the other two drugs, and I think the answer is no. I think that valacyclovir is just a lot less popular and a lot less prescribed, and at the same time there's a lot more aggressive reduction in dose according to creatinine clearance, and you can see it there. And so when you adjust the dose down more aggressively, it's also a cheaper medication. It may potentially be safer. Maybe it's something we should use more in our patients with chronic kidney disease, but it's something that really should be studied. Second last topic is antibiotics and urinary tract infections. That question comes up all the time of whether we should actually avoid nitrofurantoin in patients with chronic kidney disease because potentially it doesn't work. The monograph certainly states to avoid the drug when the creatinine clearance is less than 60 mL per minute. And when you look at the evidence, it's really based on 2 small pharmacokinetic studies demonstrating inadequate concentrations of urine, so pharmacokinetic data, inadequate concentrations when the creatinine clearance is less than 60 mL per minute. However, when you look retrospectively at, you do chart reviews, there's a number of them published. Retrospectively, a lot of people get nitrofurantoin maybe on purpose or not on purpose when their creatinine clearance is as low as 30 mL per minute. And in those cases, when you look retrospectively, it actually does seem to result in a clinical cure in almost all cases. So the question of whether it works or not, it likely does. However, what you're missing if you solely look at retrospective data on clinical cure is what happens afterwards. And when you look at these large administrative database studies that follow these patients over time, what the main concern is pulmonary toxicity. And pulmonary reactions leading to hospitalizations, the risk increases by 4 in the 90 days after the start of nitrofurantoin. So these pulmonary effects are classified either as acute or chronic. So acute typically occurs in the first 3 to 8 days. You get this sudden shortness of breath, fever, cough, eosinophilia. You may or may not have skin rash, and if you do an X-ray, you likely see edema and pleural effusions, and so it's very non-specific, and you likely don't relate it back to the fact that you used nitrofurantoin a week ago. You can also have chronic hypersensitivity. Typically occurs in patients taking nitrofurantoin over long periods of time to prevent urinary tract infections. Again, you'll see similar symptoms of a non-productive cough, dyspnea, and fibrosis of the lungs. And so we generally recommend avoiding nitrofurantoin in patients with the creatinine clearance less than 60 mL per minute. You can use other antibiotics such as ciprofloxacin, is very popular. I just remind you that maybe 1% of patients might experience a transient rise in serum creatinine in BUN. That's normal. It's nothing to be concerned about. It will go back to normal after the drug is done. Very rare, as well as crystalluria. This is when the pH is alkalinized. And that's really a concern in patients who have kidney stones and are having alkalinized urine as part of their treatment. For trimethoprim, you do get a reversible competitive inhibition of tubular secretion of creatinine. The serum creatinine can increase by 15 to 35% in 3 days, and again, that returns to normal after the medication is stopped. So the very last two slides is on acute phosphate nephropathy and what colonoscopy preparation we should use. And so when you look at the guidelines from BCPRA, they do recommend avoiding oral phosphate-containing bowel preps when the GFR is less than 60 mils per minute. And when you look at the how much phosphate is actually in 5 mils of bowel prep, about 5 mils is equivalent to about 40 cans of Coca-Cola in terms of how much phosphate is in there, which is a huge load for patients with chronic kidney disease. And that increases the risk of something called acute phosphate nephropathy, really just described due to the fact that this product even exists on the market. You can either get earlier or late phosphate nephropathy. It really only occurs in patients with chronic kidney disease. So my very last slide, bowel agents to use, polyethylene glycol in CKD patients if they can tolerate the volume. Picosalix is an alternative for patients who you think if they need less volume, but just be careful that there is magnesium in there and it can accumulate in patients with stage 4 and 5 CKD. So Dr. Levin is now in the room, and I know I went right to 30 minutes, so if you do have questions, again, type it in and include your email address. Is there anything? No questions so far, so maybe I'll turn it over to Dr. Levin.
Wait, I have one raised hand. He's not asking anything.
Does he want to ask it by phone or do we?
The type. I know.
Fine.
Before we ready.
I can just,
Yeah. So thank you, everyone.
Just place this down.
So it'll be on the desktop. It's right at the top.
There it is.
They can't see me. They can.
They can see me. It's even worse. Okay. So my finest moment. Okay. Hold on, where is this? Okay. So thanks everyone for spending your lunch hour with Cliff and I. And so my topic is chronic kidney disease, managing blood pressure and cardiovascular disease risks as part of this scenario. And just to go through things, I don't have any disclosures that are pertinent to this conversation. But what I want to talk about was chronic kidney disease and cardiovascular diseases, and you'll understand why I have it as a plural in a moment. Maybe remind us that there are both traditional and non-traditional risk factors for cardiovascular diseases in patients with kidney disease, and then go through a little bit of the evidence-based therapy for cardiovascular risk and perhaps an approach to management. So just to remind us that 1 in 10 Canadians has some degree of kidney impairment, which means about 3 million Canadians have CKD. But dialysis and transplantation, those things that are end stage, only account for about less than 1% of that group. There are specific ethnic groups such as Indigenous people, Asians, South Asians, Hispanics, and Blacks that have a higher incidence and prevalence of CKD. And that importantly, aging alone is not a cause of kidney disease, although that's often talked about. Aging is associated with multiple other conditions and drug uses that might impact kidney function, and that's why you're more likely to see impaired kidney function as you age. But there are also lots of old people, including my mother, who have normal GFRs. The possible events and outcomes of people with kidney disease, well, you can have things that are actually directly related to their kidney and not related. And the kidney related specifically they are increased risk of acute kidney injury, whether that be transient or sustained. And that's important because you get transient changes in kidney function. Some people actually have no change in their GFR over time. And as I said before, less than 1% progress to needing renal replacement therapy. The non-kidney function reduced related are that these people are increased risk of cardiovascular disease, and I'll explain why in a moment. And most importantly, it's heart failure, arrhythmias, and sudden death that are the biggest issues, more than traditional thrombotic and atherosclerotic events. There are also increased risk of infection and all-cause mortality. And as you can imagine, a lot of these things are interrelated. And so there's some hypotheses that higher infections increase inflammation, propagates cardiovascular disease, may lead to acute kidney injury on top of CKD, and you can end up in a sort of a bit of a vicious circle. That being the real point of this conversation is what are kidney patients at highest risk of, and this is a summary of a set of relative risks. So I said before, all-cause mortality, death from cardiovascular disease, which is the topic of this lunch session, kidney failure, acute kidney injury, and progressive kidney disease. Also on this slide, I could have put hospitalizations and infections. But importantly here, look and see that by GFR and by urine ACR, there are increased risks. So even when your kidney function is reasonable, if you have a high urine ACR, and that could be, for example, a diabetic who looks like they have good function but has a lot of protein, is at higher risk of cardiovascular disease. And that's how you would read this sort of a slide. But the diseases that they're at risk for include, as I said, heart failure, dysrhythmias, and then the more traditional myocardial infarction, peripheral vascular disease, and stroke. But importantly, the stroke can be both hemorrhagic and thrombotic, and that's important to remember. If one thinks about the structural and functional changes that occur in the cardiovascular system in kidney disease, you could think about them as large vessel and small vessel disease. And the large vessel disease is atherosclerosis that we all know and have lots of treatments for, and there's arteriosclerosis for which we have very few treatments. And that's where the vessels actually, the small and large vessels, actually calcify and stiffen and have arteriolar wall thickening, smooth muscle cell hypertrophy, and you get endothelial cell dysfunction, which actually increases the stress on the heart by reducing compliance of all of the vascular tree. The cardiomyopathy they get is both secondary to some of the small vessel disease as well as secondary to anemia and hypertension, and they get increasing left ventricular wall thickness, dilation of the cavity. If you look and you biopsy, they have a reduction in myocyte number and more fibrosis. And so what you end up with is a bigger, baggier heart that doesn't have a lot of healthy myocytes and also doesn't have increased vascular capacity despite its increased size. And if you look at the traditional risk factors and scoring systems and see whether or not they predict events in people with chronic kidney disease, the answer is not very well. And this slide shows the Framingham 10-year predicted versus observed rates in men and women for cardiac events. And you'll notice that there's a big gap. The CKD cohorts are in the dark bars, the hashed bars are the Framingham predicted. So there's a delta there of somewhere in the order of 6 to 10%, depending on whether it's men or women. For cardiovascular events and for mortality, that same but perhaps enunciated difference in observed versus expected from traditional risk factors. And that's what Framingham is, right? It's traditional risk factors, and I've listed them here on your left-hand side of the slide. So hypertension, diabetes, dyslipidemia, a family history of heart disease, smoking, and obesity are all reasons why people with kidney disease have cardiovascular disease. But in addition to that, there are some additional stressors, if you will, in terms of uremia itself, albuminuria, associated comorbidities like anemia, hyperparathyroidism, abnormalities of calcium phosphate, an absence of vitamin D, which may be important both in terms of controlling blood pressure as well as vascular health, and uric acid. And these are the sorts of things that people have been trying to understand, because perhaps these are the things that account for that higher risk for cardiovascular disease. So both CVD and CKD share risk factors that are important for the initiation or progression of both, and both can lead to death in at-risk populations. So it's important for us as practitioners, be it primary or specialists, that we actually address all of these. We know that in general populations, risk factor reduction has a positive impact. And we know that using ACEs or ARBs, beta blockers, and calcium channel blockers, in addition to statin therapy and antithrombotics, is actually a proven benefit in the general population. We don't know necessarily if that's true in the CKD populations, but it's important that we at least focus on that component that's modifiable and attributable to the higher risk of cardiovascular events in our population, especially the one that you as GPs and we as specialists share. So it's just some other facts that patients with early stage CKD are 5 to 10 times more likely to die from a cardiovascular event than progress, and hence the importance of addressing this. This is a nice slide using Alberta data from Cello Tonelli that actually describes the fact that if you're a CKD patient, you're actually more, if you look at the purple bar, you're actually more likely to die than someone who's previously had an MI. And if you have diabetes and chronic kidney disease, you're especially more likely to die relative to those with just diabetes or people without either of those. And the same is true of the categories if you look at who's about to have an MI. So if you had a previous MI, you're likely to have a second one. But the next most likely group are people with diabetes and CKD. And then the next most likely group are the people with a lower GFR without diabetes, and so on. So how do we actually address the major comorbidities that are associated with and lead to cardiovascular disease? So undoubtedly, the cornerstone of therapy is the treatment of blood pressure. I would say that it's important to individualize the blood pressure targets and agents according to their age and other comorbidities, and also to be sensitive to how well they tolerate the various treatments. I think we have to inquire about postural dizziness because perfect is the enemy of good, and when you have very stiff vessels and you have an older patient, you perhaps do not necessarily need to achieve all of what they put out as targets. At the moment, there's an ongoing controversy as to whether or not you should have a different target based on your ACR. I think the consensus remains that a blood pressure less than 130 on 80 is ideal in this patient population. And if you can't achieve that, then less than 140 on 90. And while there are some differential targets with urine ACR, to keep it simple, I'd just say less than 130 on 80. This is what people would suggest and what the evidence suggests is when you treat with an ACE inhibitor or an ARB. And basically, if you have diabetes but no hypertension and a negative urine ACR, that is normal, you probably don't need to put them on an ACE or an ARB in the context of impaired kidney function, but almost everybody else should. There's no data to suggest that moderate proteinuria in the absence of diabetes and hypertension should be treated with an ACE or an ARB, but that is subject to debate as well. But most people with hypertension and proteinuria should all be treated with an ACE or an ARB. One needs to monitor the blood pressure and the weight, and also hemoglobin, kidney function, bicarbonate, and potassium when treating hypertension or adjusting any medications. Albumin is a good marker of both the worsening or not of proteinuria as well as nutrition. And the urine ACR is a nice window into how well their blood pressure and are controlled. I'd caution all of you to measure BNP and troponin in people with impaired kidney function because they have to be interpreted with a fair amount of caution given that these are both affected by eGFR, and you can have, quote, elevations that are simply because of reduced excretion. So as I said, the control recommendation now is for sure less than 140 on 90 and perhaps less than 130 on 80. I'd be careful in the elderly or people with advanced chronic kidney disease or vasculopaths because escalating ACEs or ARBs to chase a urine ACR or a blood pressure of 145 usually results in either falls or worsening kidney function. And so this is not what our goal is. It's to actually maintain things steadily. So I would just advise to be cautious. I want to just switch gears and go to the treatment of cholesterol. And certainly the best data that we have is from the SHARP trial, which is a study of heart and renal protection using a combination of simvastatin and ezetrol versus placebo. It's the largest trial ever done in a kidney population, almost 10,000 patients. And almost 8,000 people randomized over a period of 5 years with a very low loss to follow-up. And this is basically the data that you get major atherosclerotic events are reduced when you give fixed dose therapy of CKD. The important thing about this is there was, and I'll get to this in a moment to enunciate it more, they had no entry criteria LDL levels. There was no escalation of dose. It was fixed dose simvastatin and fixed dose azotrol given at night on a background of other therapies in a wide group of patients around the world of different ethnicities, very low toxicity and very high gain in reduction of atherosclerotic events. The important thing about this study is that all-cause mortality was not impacted, but if you recall back to my earlier slide, there are 2 reasons why people get cardiovascular disease. One is the traditional atherosclerotic events, and that's, you recall, what the Framingham actually predicts. And then there's a big delta or a gap of cardiac events that occur that are not primarily atherosclerotic. So in as much as we reduced the burden of atherosclerotic disease, the SIMVA and EASY, you reduced those events, but you couldn't impact full mortality because there's another reason why people with kidney disease die. So the recommendations are to treat those at high risk for atherosclerotic disease with lipid-lowering regimens, regardless of their LDL levels, because those were not an entry criteria in SHARP, but if they're over the age of 50. And so that would be one of the things that one might go to one's practice and see if your GFR is over 30 and you're over 50 and you're at risk for atherosclerotic events. One of the practical caveats is if you've never had an atherosclerotic event and you're 85 years old and your GFR is 40, I don't think you need to start any lipid-lowering therapy. So let's just go back to some of the other common factors. So what I really dealt with most is the hypertension and dyslipidemia, because those are the things that for which we have the most A, evidence, and B, armamentarium. The non-traditional factors that are probably associated with cardiovascular and kidney disease are listed on that slide, and what I've highlighted in italics there is vitamin D deficiency and uric acid, for which there's some interesting information, and your patients or others may come to you about it, so I just thought it was worth addressing. So uric acid is thought to actually contribute to endothelial cell dysfunction, oxidative stress, and a number of other things. And so there's some controversy about whether one should lower high levels in the absence of any gout. There's some very interesting basic science animal and small clinical trials that suggest a benefit to GFR, vascular stiffness, and blood pressure if you actually lower uric acid with Allopurinol or Febuxostat. And so you may find that some nephrologists are giving Allopurinol for cardiovascular protection, but let me say that there are large trials to see whether or not this holds over large holds up over above and beyond the small clinical trials, and it wouldn't be something that is currently recommended. With respect to vitamin D supplementation, again, there's basic science and animal studies that suggest the role of vitamin D in vascular health. There are vitamin D receptors on vascular endothelium, and you can show that activation reduces blood pressure because it interferes with renin. But there's a lot of conflicting data in clinical trials as to whether or not it's really a benefit. No question that there's a very low risk of harm. In chronic kidney disease populations, there's a relatively consistent signal that vitamin D supplementation is probably okay, but we don't know, amongst all the other things that they're getting, whether or not it's really a value to add it and what type to add. So that, again, is data that is coming, but often for those of you that have patients that come to kidney care clinics, you'll see that sometimes they're on plain vitamin D3, sometimes they're on a 1-alpha calcidiol, which is an active form of vitamin D, and you'll find that it's slightly all over the map, but there is some physiological rationale as to why we might be doing this. So what I've tried to do is give you a feel for the cardiovascular disease, which is both arteriosclerotic and atherosclerotic, in this group of patients, and that's very multifactorial. And trying to sort out which things are the most important in which patients is not so simple, but it is complicated. But I would say that if we stick to the notion that treating blood pressure and cholesterol, the conventional things, is good, then I think the principles are that kidney disease is seen in association with lots of other conditions, that you do have to regularly monitor and give them surveillance, both for feedback to the patients, adherence and adjustments, as well as safety issues. We do regular interval blood work so that we know what the trends are. That's also important when you're trying to identify whether the current event or illness that impacts the trajectory. And if you regularly review blood pressure, weight, and medications in the context of cardiovascular disease symptoms and treatment strategies, that's probably of benefit. And again, remember, these are all one people, so we try very hard to have an integrated strategy of managing their cardiovascular disease, diabetes, and kidney disease. A final word about patient safety. I think adjusting medications or over-adjusting medications is important, and try avoiding ones that you know are nephrotoxic. Certainly dye, if it's not an essential study, should be avoided or minimized. And remember to tell patients, especially in hot BC summers, to avoid ECF volume contraction and drink a fair amount of water. We regularly in the clinic, and you would in your offices, adjust doses and avoid drugs which are nephrotoxic. And whenever I start or stop any new medication or expose them to dye, or they have an episode of severe nausea, vomiting, or an intercurrent illness, and even if I adjust up or down a dose of an ACE or an ARB, I'll always repeat the EGFR and urinary CR to establish what my new baseline is or isn't, and it gives everyone a feeling of a better understanding of the biology of this. So what I've tried to do in the last 20 minutes, gives a bit of time for discussion, is give you sort of the overview of chronic kidney disease and the variety of cardiovascular diseases to which they're subject, review briefly traditional and non-traditional risk factors, and re-emphasize that there is evidence-based therapy for cardiovascular risk reduction. It's no different than what you're doing with all your other patients, so you shouldn't be afraid of it. It's blood pressure control, ACE and ARB, and cholesterol lowering strategies, irrespective of what their cholesterol level is. So I'm going to stop there and be happy to answer any questions or concerns that you may have, or things that I've confused you about. So I'll stop there and ask Sidonia if there's any questions or thoughts?
No questions yet. The last time they took it wait till the very end. So.
And is the very end? For Cliff or for I guess, because Cliff is in the room too. I'm assuming you're all still there. No?
See the flashing thing on the side there.
No, there's no questions.
Oh, Sidonia was typing something into the question thingy.
Mm-hmm. Oh, here we go.
Here we go. Yeah.
What about traditional nephrotoxic antibiotics?
Traditional nephrotoxic, you mean nitrofurantoin?
Nitrofurantoin or aminoglycosides?
Aminoglycoside, I mean, I think, like all things, drugs dosed appropriately for the right reason are good. Tetracycline is not in and of itself nephrotoxic.
I think there's some old data about tetracycline itself. I think there was some older data that increased serum creatinine. I can't remember the exact details, but doxycycline has never been shown to, and that's what's typically used these days. Yeah. Erythromycin, I don't think.
I mean, a lot of these things you will, as you pointed in your talk, you'll get a transient rise in your creatinine. Sometimes it's because they're not eating as well and they get the ECF line contracted when they're on some of these drugs. Sometimes it's because some of the drugs interfere with creatinine excretion. Our experience is that Cipro often increases the serum creatinine, which often comes back to normal post, but you can't tell because they often have a UTI at the same time. So is that what's causing it, or is it the Cipro? So I guess we wouldn't deny people the right drug. I think it's a matter of ensuring that their creatinines come back to baseline after you stop the drug. And I usually wait 10 days after their UTI to retest their creatinine if it's gone up.
We have one question from Kelowna. He said, are we still using targets for cholesterol? And is there a goal to driving ACR down?
Great questions. So the goal for ACR is to reduce it. As I said before, perfect is the enemy of good, and so careful what you wish for. So if it's an old lady with a good blood pressure and she has a high urine ACR, if you have it and she doesn't fall over from the medicine that you give her with an ACR and ARB, that's good. If you make her blood pressure too low and she falls over, you've probably done a bad thing. So I don't try and get it to zero. I try and reduce it, and usually try and reduce it by half. Part of it depends on how high you're starting. A urinary ACR of 10 that goes down to 3 is probably terrific. A urinary ACR that's 50 that goes to 15 is probably terrific. So I think that's that target. The cholesterol targets, it's not so clear. So the study, SHARP, showed that if you reduce cholesterol from any level by 1 millimole per liter, you will confer the exact same benefit as you would in a general population. So whether you go from 3 to 2 or 2 to 1, it doesn't matter. So any reduction from any level is of benefit. Hopefully that makes it understandable.
Right. I think that's the general sort of consensus with lipid-lowering therapies. It's the pleiotropic effects of statins and all the other things it does, rather than specifically lowering LDL to a certain target, and not just in kidney disease patients, but
in all.
That's it. 4 minutes.
4 minutes for your questions. Counting. It's okay. Lunch and learn, right?
Some people say no.
Okay. Well, thanks very much for all your attention and for your questions. And if you think of any after the fact, then feel free to email Sidonie, and then she'll pass them on. We're happy to answer them back by email.
Absolutely. Thank you so much.
One more?
No, I'm just saying thank you.
Okay, great. Okay, thanks.
Yeah.
Good.
Thank you.
Look at that.